Okay, let's talk about burns. Now, the good thing about burns is you have a chapter in your Med-Surg book that is directly related to burns, so all of your information is going to be condensed right here. As we talk about burns, we have to understand the pathophysiological changes that go on with burns and all of the different types of burns that your clients can have, because that's going to impact your assessment findings on your client, your interventions that you're going to do for your client, and so forth. So when we look at different types of burns, it really depends on what type of burn the client has that directs your assessment and your care for that individual. If somebody comes in with a thermal burn, let's look at just some examples of all of these different types of burns. So a thermal burn is like liquid, steam, fire, like a flame or a flash. Like if you're cooking something and there's a lot of steam coming off of the item that you're cooking, of course that can cause a burn. Liquids, we're familiar with liquids, how that can cause a burn. Fire, flame, or flash. Now when we look at chemicals, the thing about chemicals are that chemicals can come in different forms. They can come in a gas form, because some of us know about that when we were cleaning or mixing chemicals, let's just say in our bathroom because it was dirty and we wanted to get it clean, so we just thought, oh, let me just dump 2 or 3 products in there, and it caused a chemical reaction and these fumes developed, and that can cause a burn if you inhale that. So chemicals can be a gas form, can be a powdered form, or it could be a liquid form. So it depends on the form of the chemical as to what type of burn we may see. Smoke and inhalation, that's going to cause a lot of upper airway injury if someone inhales smoke, and that's not good because then we're worried about their airway being compromised and failing, which is not good if somebody gets into that situation. Now your electrical burns. With your electrical burns, and your really bad electrical burns, you're going to have 2 different wounds, so to speak, because you're going to have an entry point and you're going to have an exit point. The bad thing about electrical burns are not only the 2 areas that you're going to see, that entry and exit, but I want you to think about it. When electricity goes in to the body, like if somebody grabbed a wire that was hot, so to speak, full of electricity, and it blows out through their other hand, think about the pathway that electrical current had to travel to get to that exit point. And inside the body, there's going to be damage that occurs all along the way between that entry and that exit wound. Now, we know sometimes when individuals touch an electrical force, it can throw them across the room or across a field or wherever. So as a result of the person coming in contact with the electrical force and it forcefully throwing them a distance, then there's the risk of that client having other injuries as well, like fractures or potential head injuries. Just depends on what they hit with that traveling that they had as a result of touching that electrical force. So there's damage that goes on internally with electrical burns. I've got to think about my heart. I think about the damage to bones that can happen, we said, because of being forcefully thrown with electrical current, and then muscles can be destroyed. And my main muscle that I'm concerned about is obviously my heart, right? Now, cold, thermal, that's going to be like your frostbite. And then we have radiation. First thing that comes to my mind when I see the word radiation is someone getting treatment for a cancer, and they can have a radiation burn from that radiation that they're receiving from that. But another example of radiation could be sun exposure. Sometimes we know burns can be prevented, and probably somewhere along in the courses of your nursing, you have learned about preventing injury when at all possible. So if we can do anything to help prevent burns, that says we're safe, right? So we need to educate individuals on how to prevent a lot of these burns from happening. So doing things like checking the labels for any kind of chemical reaction that may happen, or if they have small children in the home, I think about all those safety measures like plugging the electrical sockets or covering the electrical sockets so small children don't stick their fingers in it. All those safety things like making sure that when they're cooking, their pot handles are turned in. Make sure that the stove is well secured so a small child can't necessarily climb on top of it and pull the stove over on top of them. Avoiding the use of tablecloths and things like that if they're putting hot surfaces on a table that has a tablecloth. So prevention plays an important part in being safe for our individuals. Now let's look at some factors that help determine the severity. These are the things that I want to know or I want to evaluate when a patient comes in for a burn. I'm going to look and see the depth of the burn. So when I'm thinking about the depth of the burn, I am thinking about how many tissue layers are involved. Is it just a very superficial burn? Maybe somebody, have you ever as a small child got drug across some carpet and you got carpet burn? Well, there you go. That's a type of burn. But that's just superficial. And remember how painful that was? Those little carpet burns can hurt, can't they? So is it superficial? Is it like a partial thickness burn? Is it maybe a full thickness burn? Is it really, really deep? So that tells me if it's a partial thickness versus a full thickness burn, the depth of tissue layers that are involved, and that determines how severe the burn is. There is a good little table in your Med-Surg book that talks about the classification of burn injury, whether it is considered a minor burn, if it's a moderate burn, or if it's a major burn. I would look over that table because that's got some good information that helps you understand the significance of the severity of the burn based on these things that are listed in this table. Now, the extent of the burn, this is when we're talking about total body surface area. Total body surface area that's affected. And so it makes sense that the greater the total body surface area that's affected, the more severe this burn is going to be. So, we're going to talk about how to calculate the total body surface area. You'll see it abbreviated TBSA. So when you see in all capitals TBSA, that is total body surface area. We have to think about the location of the burn because we know if someone has a burn, let's just say covering their whole face, that would be bad because all the swelling from the burn is going to affect their airway. Or if they had a burn that was completely covering their chest, that could interfere with the expansion of their chest and the ability to take deep breaths, so that could affect my airway. If it was one on the leg, I wouldn't think about that being as severe as a burn that was in my face or on my neck or my chest area because of the respiratory system that's involved with that. So the location of the burn does play into how severe it is. And then look at their medical history. Is this somebody that has no medical problems at all? Or we might be dealing with a client who is complicated with diabetes, peripheral vascular disease, maybe some type of lung or kidney disease. That's going to affect their outcome and their ability to heal. Now, here we have the rule of nines. This is the rule we will use when you're trying to calculate total body surface area that is affected, or TBSA. So we got this picture here, and there's also one in your book if you want to refer to that one also. So let's take a look at the rule of nines and how we calculate total body surface area that's affected. So we can see the head, and they actually include the neck in the 4.5. We're going to start at the top. I'm sorry, let's just say that's 9, because 4.5 is on the front, 4.5 is on the back. So when they say the rule of nines, it's like the front and the back. So our head and neck, the whole thing, all the way around, would count for 9%. Again, if you divided it with anterior, front, 4.5, or posterior, back, 4.5, and when you add those two together, you come up with 9. Now let's move on down the patient's body. You can see where it's kind of diagramming and cutting off the anterior chest down to the lower abdomen. All of that is part of that front, so that's 18%. So your front, if it says your front, the patient's chest or abdomen, then that's going to include the whole 18%. We refer to it as their trunk. So if it said their anterior trunk, it's referring to that 18% right there. And then the same thing for the back. If it said posterior trunk, then that's going to count for 18%. So then let's look at our arms. Each arm all the way around counts for 9%. Each arm is 9%. So my right arm is 9, my left arm is 9. If our example said that the anterior right arm was burned, then how much are we going to count for that? That's right, 4.5. Because if the whole arm is 9 and only the anterior is affected, then that's half of that, which is 4.5. Let's move on down. Genitalia counts 1%. 1% for there. When you move down to the leg, the whole right leg is 18%, whole left leg is 18%. So again, if it said, like if they were burned just on the anterior part of their left leg, that's going to be 9, because half of 18 is 9. We could break it down even further. If it said that they were burned on the anterior surface from their knee all the way down, including their foot, how much would that be? Well, if I know the whole leg is 18, but this is just on the front side of the leg, I know the front side counts for 9, right? Well, if we're only burned from the knee all the way down to the foot, that's approximately half of the front side of their leg. So I would have to take 9, divide that further in half, and I would get 4.5. So let's start at the top. Let's refresh. Head and neck. Remember, we're talking about all the way around, 9%. Anterior trunk or anterior chest, 18%. Posterior trunk, 18%. Right arm, all the arm is 9. Left arm is 9. Each leg is 18. And genitalia is 1. You have got to memorize those numbers because you're going to need them for NCLEX when you're calculating total body surface area, and you're going to need them for our test also. So make sure you understand and you follow the rule of nines. Now, let's look at after the burn occurs, what do we do? Because there are different phases of the burn that we look at, because in these different phases, there are going to be physiological changes that go on in each phase, and so my focus is going to be a little bit different in each phase. So, when we look at pre-hospital or emergency care, I think about, okay, the burn just happened. They just got exposed to that chemical, or maybe the electricity, or the fire itself, then we have to think about, what are my priorities in this situation right after the burn happened? Well, fortunately for you, you have got a really great resource in your book. There is a chart on page 489 in your book, and it is best practice for patient quality, safety, and quality in the emergency management of burns. And it breaks it down for you. What is your management for all types of burns? And for specific burns that your client may have. Definitely a good chart for you to go back and look at to help you to understand, in that emergency phase, what am I going to do? Now, look at the situation that the question maybe on NCLEX, or the question that we give you, puts you in. If it tells you are in a field somewhere providing care during the emergency phase or during that pre-hospital phase, I don't think you're going to have any IV resources and things to be able to start a line on your client, right? So look at the situation that you're in, but you can do other things in that situation, like assess their airway, keep them in PO, stay with them, stay safe, elevate that extremity or wherever the burn is. So there are some things you can do in that situation to help your client. But we can see it's very specific, outlined very clearly for you as to what you're going to do in each and every situation with those burns. I do want to point out a few things in that information there in relation to your chemical burns. Pay attention to the fact that you do want to remove the chemical first. If it's a powdered chemical, you want to brush off that powder. You want to remove any clothing that has that chemical on it, whether it's a liquid, a powder, whatever. You want to remove that clothing that has that chemical on it. And then it tells you in your book, brush off that dry chemical that's on the skin or the clothing, remove their clothing, and then you want to flush. We're going to flush the area for at least 20 minutes with any type of chemical exposure. Remove the clothing. If it's a powder, brush it off, and then you want to flush for a minimum of 20 minutes and possibly up to 2 hours after exposure to that chemical. Look at your priority on your electrical burns. You're going to, of course, make sure that they have been removed from the electrical current itself. If there's any flames, smother it out. And then check their cardiac status, because electrical injuries are very damaging to the heart. So you may have to start CPR on them. But let's just say that your client comes to the emergency room telling you about their electrical injury that they've had. They're breathing, they're talking, they walk into the ER and tell you they don't know what the big deal is, but they feel fine. The very first thing that you as the nurse should do is put them on an EKG monitor. That's right, put them on an EKG monitor. And they're going to stay on that monitor for at least 24 hours. We want to monitor that heart for at least 24 hours because there is an arrhythmia that they are at risk for after an electrical injury. And do you know which one it is? VFib. Okay? They're at risk for VFib after an electrical injury. So that's why we have to monitor them for 24 hours after that burn, after that exposure to the electricity. Now, let's look at what is called the emergent or the resuscitation phase. This emergent or resuscitation phase is when occurs within the first 24 to 48 hours after their burn. There are a lot of physiological changes that go on with a major burn in that first 24 to 48 hours. Your book does a phenomenal job of going over every single area that's listed here and what happens in each specific body system. Now, when I look at these body systems that are listed here, and this is not in priority of how you would assess or take care of, we just need to understand how each of these systems is affected with a major burn. First of all, your skin assessment. That's easy. We got that. That's that rule of nines. That's that total body surface area that's affected that we've got to determine. And in that TBSA, we're also going to look at the depth of the burn. We talked about how that can impact care for my client. When I go on and look at fluid and electrolyte shifts, in your book, I want you to go back and on page 485, it breaks down things very clearly for you, like vascular changes. That's going to be your fluid and electrolyte shifts and things that go on there. So look at your book starting on page 485 with vascular changes, with cardiac changes, with pulmonary changes, with GI changes, metabolic changes. Go through that because it does a really good job of helping you understand what goes on in these body systems when a client does have a major burn. Let's first briefly talk about fluid shifts that go on. This client's had a major burn. We want our fluid in our body to be in that intravascular space. Yeah, we have some in the interstitial spaces too. I get it. That's important too. But what the shift that I'm focusing on here is the shift that goes on from intravascular. It shifts out into the interstitial spaces, which is not good because if I'm decreasing my vascular volume, I've just decreased my perfusion, right? And that is not good. I need to perfuse my vital organs. That's why you're going to see in this first 24 to 48 hours, fluid replacement is so important. So important. We've got to maintain perfusion. These individuals can go into hypovolemic shock. And you know when somebody goes into shock, their blood pressure goes down, their heart rate goes up. We've got to start 2 large bore IVs. We've got to get some fluids back in them very, very quickly. And we're going to talk about how much fluid and that sort of thing in just a minute when we look at our Parkland formula. So low volume, they're going to have some changes with their electrolytes. And the specific electrolytes that we look at, one is hyperkalemia. Hyperkalemia. So now we got somebody that has a lot of potassium floating around. You know, potassium likes to live in the cellular component inside of our cells. But if I've had a major burn, my cells rupture or they lyse. So when my cells rupture, that's containing the potassium, now that potassium is in the intravascular and it's elevated in the intravascular space, which is not good. Now I'm going to have signs and symptoms of hyperkalemia, which I know that's damaging to my muscles, right? Then you're going to see hyponatremia. Hyponatremia. So 2 major electrolytes that get shifted around and displaced are potassium, hyperkalemia, sodium, hyponatremia. Now the reason they have these fluid shifts is because they have an increase in their capillary permeability. Okay, let's just talk about it like this. Our capillaries in our body are permeable. We know that because things can shift in and out of our intravascular space, right? Well, if we increase the permeability, that just means that we've increased the ability of fluids to shift around, which is not good. We don't need that. So because they have this increased permeability, they've had this major burn, now fluid is moving from the intravascular out their third spacing. That's when you see third spacing develop. That's why everything starts swelling up from inflammation from the burn itself and injury to the tissue, but also because fluid is shifting out, which complicates things. And then I'm having these changes in their electrolytes. So as a result of this, think about now my cardiovascular system. What's going to happen to my circulatory system? Well, we said everything is shifting out, right? Low volume in my vascular space. So am I going to be perfusing things very well? What's my heart rate going to do as a result of that? It's going to go up. What's my cardiac output going to do as a result of that? It's going to go down, right? Think about, with the circulatory system, if somebody has a circumferential burn. Circumferential means it goes what? All the way around, right? All the way around. So if I have an area that has a burn and it's going all the way around, what is my priority? What am I concerned about? That's right. I'm worried about perfusion distally to where that circumferential burn has happened. That's going to cut off circulation to that area. So this may require for the client to have an escharotomy or a fasciotomy. What is the goal of an escharotomy or a fasciotomy? It is to restore circulation, open up everything, get that circulation going back to that distal point past that circumferential burn. If somebody has an electrical burn, when I think about the circulatory system, I think about checking those pulses, making sure that they stay present, and fluids. Fluids are going to be so important in our clients during this phase. Now let's look at the respiratory system. Of course, when somebody comes in with a major burn, that's going to be one of the first things that we do is make sure that their airway is not compromised. How are we going to know if somebody has a suspected upper airway injury because of the burn that they have? Let's say there's a house on fire and the client runs in to try to rescue the pets or something in the home and comes out and they have this major burn all over their arm. So you take them to the ER. Could that individual, even though they only have major burns visible on their right arm, could they have an airway injury as well? Yes, as a result of going in and inhaling all of the smoke and everything that's there. So what do I need to look for in my client? I would need to look for any kind of upper airway injury, like do they have soot on their face, black stuff that's all over their face? Is their facial hair singed or burned? What about their nose hairs? I would need to look in their mouth to see if they have any blisters in their mouth and around their nose. Look at their eyebrows. If it's a female and if they don't have facial hair, look at their eyebrows, look at their eyelashes. So check and see if there's any potential upper airway injury from inhalation of smoke. So if all that's clear, then I can go and listen to their lung sounds, check their O2 sat, and assume that they're fine. If somebody comes in with a suspected upper airway injury, they have a lot of smoke, they have a lot of soot, maybe they're coughing up black specks in their sputum, or if they're clearing their throat a lot, then that tells me that they have potentially got some injury in there, and it depends on the severity of the burns and the healthcare provider's evaluation. Some of these patients may get intubated prophylactically. Did you hear me? Some of these patients may get intubated prophylactically. If they determine by looking at them that there's the chance that their respiratory system can shut down because of all the smoke inhalation or the swelling that they see that has started, they may go ahead and intubate them to support that respiratory system, because if they don't go ahead and intubate them and swelling continues to occur in their facial area, in their neck, then it could completely shut off and they may have to trach them. So intubation prophylactically may be something that they have to do. Keep a check on your patient's O2 sat. But let me tell you what, if somebody has carbon monoxide poisoning, and you put an O2 sat on them, they can still sat within a normal range, but be hypoxic. Did you hear me? Patients with carbon monoxide, you can put an O2 sat on them and it look normal, but they can be hypoxic. And do you know why? That's because carbon monoxide binds in the cellular level, okay? It binds to the hemoglobin. Well, if your carbon monoxide is bound to your hemoglobin, then that makes it where there's no room for your oxygen to bind to it. So if your oxygen can't bind to your hemoglobin, you're going to be hypoxic. So carbon monoxide binds to the hemoglobin, doesn't leave any room for the oxygen to bind to it, so your client becomes hypoxic. So here we're just going to have to keep a check on their vital signs. We're going to have to keep a check on their mental status, see if they're getting restless or anxious, because that could indicate hypoxia. And I would want to check a carboxyhemoglobin level on them. Now let's move on to the urinary system. When somebody comes in with a major burn, we've already talked about how the fluid shifts out, right? So if all of my fluid intravascular is shifting out, I'm thinking they've got decreased perfusion. When I have decreased perfusion, I want to maintain some perfusion to my vital organs, which is my heart, my lungs, my kidneys, and my brain. Okay, my heart, lung, kidneys, and brain. That's the 4 major vital organs that I think about that I need to keep perfusing. Well, if I've had decreased volume, am I going to have decreased blood flow go into my kidneys? Yes. So how do I know that this patient's kidney function is not being affected by their loss of fluid? I'm going to check their urinary output. That urinary output is going to help determine if the fluid replacement that I'm giving them is adequate. So for this individual, I got to put a Foley catheter in them, an indwelling catheter in them, and I'm going to measure that urinary output every hour. Measure that urinary output every hour. And you know what you want a minimum urinary output to be on somebody, 30 to 50, right? 30 to 50. But here, I want an even more precise way of measuring their urinary output, and it's going to be based on their weight. This client needs to have a urinary output of at least 0.5 to 1 milliliter per kilogram in an hour, okay? Again, I'm going to be checking that urinary output every single hour, and it needs to be a minimum of 0.5 to 1 milliliter per kilogram in an hour. And that's going to be at least 30 to 50, all right? So I'm going to be checking that. I'm also going to be checking that urinary output for the color of it. If someone has severe enough damage from their burn, I'm going to be looking for myoglobin to be released, which we know is a result of breakdown of muscle tissue and damage that can happen. So all of this myoglobin breakdown, all this tissue cells that are broken down can clog up my kidneys. So watch for the color of their urine. Don't be alarmed if their urine is like a dark or a rust colored urine. That's the pigment produced by the breakdown, the heme pigment produced by the breakdown of the hemoglobin that comes. So watch the color of their urine as well when you're monitoring their urinary output. One other thing with the urinary system, if somebody has an electrical injury, okay, they have an electrical injury, we want their urinary output to be even higher than normal, okay? So if somebody has an electrical injury, then we want their urinary output to be at least 75 milliliters an hour. Okay, we want their urinary output to be 75 milliliters an hour if it is an electrical injury. And that's because with an electrical injury, they have a lot of tissue destruction that goes on, and we're worried about the kidney function. So their urinary output needs to be higher than with a regular burn. Again, my kidney problems all boil down to lack of perfusion. If I'm going to have some kidney problems, it boils down to lack of perfusion, which we know that as pre-renal failure. Okay, pre-renal means blood flow can't get to the kidneys. And y'all learned about renal damage, pre-renal. So it's going to come from low volume, and it's also going to come from the destruction of cells, your myoglobin and your hemoglobin, and all the tissue cells that get destroyed, and they've got to have a way to come out of the body, and it comes out through the urinary system. So all of those breakdown and destruction of cells can clog up the kidneys. That's why it's so important we put that indwelling catheter in, measure their urinary output every hour, and we know what the minimum output is supposed to be for those individuals. Now, sometimes you will see the drug mannitol administered if they're worried about their kidney function. So, mannitol. We're familiar with mannitol, osmotic diuretic, works by pulling fluid from the brain. So when I give somebody mannitol, how would I know if it's going to work? I would expect to see that their urinary output should go up because I'm shifting more volume into my intravascular. And when you put volume in that vascular space, you're going to perfuse better. You're going to get more blood flow going to your kidneys. So as a result, your urinary output's going to go up. That's right, going to go up. Let's move on and let's talk about the GI system. Remember, GI tract, everything just kind of slows down and shuts down. It's a normal stress response from the body when your GI tract just slows down because of any kind of major stressor on the body. So really watch their bowel sounds, checking those bowel sounds closely. You may see an NG tube put down on this person if they suspect that they may develop a paralytic ileus, or even if they have an ileus. That's just a standard. Somebody has an ileus, that means their gut's not working. They're going to have to put an NG tube down and hook it up to suction. So don't be surprised if you see an NG tube placed on this person, maybe later on for feeding, but initially it's probably going to be just to decompress the belly, keep everything moving, because of the resultant volume and the reduction of volume and the reduction of perfusion go into the GI. Everything just kind of slows down. This person is at risk for developing an ulcer because of the stress that's on their body. We know ulcers can bleed, so I would be watching for changes in their stool. This person's probably going to be put on some type of proton pump inhibitor, PPI, H2 antagonist, some type of stomach protectant medication to keep them from developing an ulcer. Now, the ulcer that these people, if they get, there's a name for it, and it's in your book, and it's called a Curling's ulcer. Curling, C-U-R-L-I-N-G''S. So they're at risk for developing ulcers. Pain management, that's going to be very important for these individuals. They're going to be in a lot of pain. Initially, we're talking about in this emergent resuscitation phase, 24 to 48 hours after they've had their burn. So you'll see some heavy medicines given to help relieve their pain, maybe some sedatives, some hypnotics. Longer term, they're going to need other different types of pain management. Now, let's look at the Parkland formula. The Parkland formula is something you will have to memorize, okay? You will have to memorize and understand the Parkland formula. This determines how much fluid we give our individual based on a couple of different things. It's based on the total body surface area that's affected and their weight. So when someone comes in after they've had a burn, we're going to start 2 IVs on them, large bore IVs. We need to get their weight in kilograms and determine the body surface area that's affected. Remember, all the fluid's shifting out, so we've got to get that fluid in quick. So this is the formula. You take 4 milliliters, multiply it by the total body surface area that's affected. So let's just say, for example, they had a 30% total body surface area. You would just take the number 30. Don't multiply it by the actual percent number, because 30% is 0.30, right? So don't multiply it by that. Just take it by that whole number of 30 or 70 or 50, whatever you calculate your total body surface area. So 4 times total body surface area times their weight in kilograms. And you can see we give the first half of the solution, give half of the solution in the first 8 hours, and then you give the other half in the next 16. Now we're going to watch a video that demonstrates how to calculate the Parkland formula.
What is the Parkland burn formula? It's a calculation used to calculate the total volume of fluids that a patient's going to need about 24 hours after receiving some type of severe burn. Usually we're talking about partial thickness, which is the 2nd degree burn, or higher. And what it takes into account is the patient's percentage of body surface area that is burned. So you need to know how to calculate that, and you will do that by using the rule of 9s. And if you don't know how to do that, I have a video that can help you learn how to do that. It's really quick and easy because that's the whole backbone of working this calculation. Also, you need to know the patient's weight, and you will take the amount of fluid, multiply all that together, and you'll get the total volume. And the solution usually used is lactated Ringer's, which is an isotonic solution that will help expand that intravascular compartment. Because when patients, adult patients who have burns that cover about 15 to 25% or more of their body, they need fluid resuscitation. Because what's going on? Well, when you get a burn, you're going to have a change to the capillary permeability. It's going to increase. So instead of fluid staying in the intravascular system, it's going to move out into the interstitial system. And this is going to deplete our intravascular system. And our heart isn't going to have a lot of fluid to pump throughout the body. And our body needs it, especially those vital organs. So our patient can enter into hypovolemic shock. So it's important we calculate with this formula so we can determine based on how bad they're burned, how much they weigh, how much fluid they're going to need over the next 24 hours. So you get your total, and then during the first 8 hours, the patient will receive half that volume total. Then over the next 16 hours, they'll receive the other half. So now let's work a sample practice problem. Our problem says a 46-year-old male patient has partial thickness burns on the anterior head and neck, the front and back of the left arm, the front of the right arm, posterior trunk, the front and back of the right leg, and the back of the left leg. The patient weighs 180 pounds. Using the Parkland-Burn formula to calculate fluid replacement, calculate the hourly fluid rate, milliliters per hour, for this patient over the next 24 hours. So to solve, let's do the easiest thing first. Let's figure out our patient's weight in kilograms because they gave it to us in pounds. So to convert to kilograms, we're going to divide by 2.2, and 180 divided by 2.2 gives us 81.8 kilograms, and we're going to round up to 82 kilograms. So our patient weighs 82 kilograms. Okay, now for the tedious part, the hardest part of really solving this whole formula is we got to calculate the percentage of the body surface area that is burned. Okay, so we have the anterior head and neck. What does that equal? That equals 4.5%. So we'll write that in. Okay, we have the front and the back of the left arm. So we're looking at the front and the back. The left arm, each side's worth 4.5%. 4.5 plus 4.5 equals 9%. The front of the right arm equals 4.5%. The posterior trunk equals 18%. The front and the back of the right leg, so each side equals 9. So 9 plus 9, because we're talking about the front and the back, is 18%. And then we have the back of the left leg, and that equals 9%. So when we add all that up, what do we get for our total surface body area that is burned? We get 63%. So now what we got to do is multiply, and we'll get our total volume that we need of LR. So 4 times 63 times 82 equals 20,664. That's our total volume that needs to go in of LR. Now, our problem wants to know how we're going to run this fluid over the next 24 hours. And what's the key with it? Half of this amount is going to go in over the next 8 hours, over those first 8 hours, half of this. Then over the next 16 hours, the other half is going to run. So where are we going to set our pump to? So let's figure it out. So what's half of 20,664? It's 10,332. So that's what needs to go in volume-wise over the first 8 hours. But we need to know what to run that at. So we're going to take this number and we're going to divide it by 8. And this will give us our hourly rate. So 10,332 divided by 8 equals 1,291.5, but we're going to round up to 1,292 milliliters per hour. So that needs to be their hourly rate during the first 8 hours. Now we need to figure out what their hourly rate is going to be over the next 16 hours. So again, we're going to be giving the other half, so we'll be left with this. So 10,332, and it's going to go over 16 hours, so we're going to divide that by 16. And that's going to give us 645.75, and we're going to round to the nearest whole number. So we'll round to 646 milliliters per hour, and that's what we'll set it on over those next 16 hours. So again, just to recap, our answer for the total volume that's going to go in over those 24 hours is 20,664 milliliters. But during the first 8 hours, we're going to infuse that at a rate at 1,292 milliliters per hour to give that first half. Then we're going to give the second half over 16 hours, and we're going to run that at a rate of 646 milliliters per hour. Okay, so that wraps up this review on the Parkland-Burn formula. Thank you.
So I do want to clarify one thing in that example that she just used. Make sure you do not round any of your numbers up until the very end of the problem. I think she rounded her weight up. So make sure you do not round any of your numbers up until the very end, and then follow exactly where the question tells you to round, just like we've always given you. You've seen with the Parkland formula, the solution that we're going to use is LR, because that's an isotonic solution. We've got to get in there, we've got to reperfuse, we've got to increase that intravascular volume to get our kidneys, make sure that they're continuing to function, make sure my cardiac output's adequate, and make sure I continue to perfuse those vital organs. Now, after the first 36 to 48 hours, now we move into the acute phase. So here we are just now focusing on maintaining their respiratory status. We're trying to maintain that cardiovascular status. And this is when we're going to start seeing our lab values kind of start shifting back around. Our fluid status should be stable at this point. I shouldn't be worried about any more fluid volume shifts. My capillary permeability is returned back to normal. And so here my focus switches a little bit differently to now more, okay, they're stabilized, they're not unstable, they're secure with everything, with their fluids and all of that. I'm just here trying to manage it and kind of ride them on out with their burn process. So I do need to, even though it doesn't say it on this slide, I need to think about their lab values kind of change. They now kind of shift to possibly hypernatremia, whereas before they were hyponatremic with their sodium. So we now can see the fluids and the sodium shifting back. So they may be at risk for hyper. They may still have some hyponatremia though. But in other words, sodium is one thing we're still going to keep an eye on. And then watch that hyperkalemia. Hopefully that's leveling out. We know hyperkalemia can cause a lot of problems if they've got a lot of diarrhea or vomiting as a result of their burn, or the situation that their body is stressed out, or if they have an NG tube that we put down earlier for that ileus is hooked up to suction. We know that can affect their electrolytes. I'm still going to keep a check on that potassium and their sodium. Here I'm going to be focusing on infection prevention, sterile dressing changes, making sure that I implement that, precautions to keep them from getting infections, because now they're at risk for infection because they've lost that first line of defense. They've lost their skin because of the burn. My wound care, hydrotherapy may be needed. The goal of hydrotherapy or Whirlpool is to remove any dead tissue. It does help to stimulate the wound bed to produce more cells and increase perfusion to the area, but generally your Whirlpool therapies are to remove any kind of necrotic or dead tissue. They may do surgical debridement. Again, that's to remove any dead tissue, or they may graft the area to help with wound healing. Pain management, we'll have to focus on that. Hopefully by now the patient can switch more to PO medications and tolerate those. Focus on temperature regulation. Again, they've lost that first line of temperature regulation by losing their skin. And then nutrition, I got to think about healing, wound care healing, keeping my client nutritionally well. So basically in this phase, I'm just trying to kind of maintain and prevent any long-term complications that can develop. Now the rehabilitation phase, this is where the client can develop, as a result of new tissue rebuilding and repairing, they can develop scarring over that area, because we know brand new skin doesn't have as much flexibility. So as a result, they can develop contractures, either from immobility or from the actual tissue as it grows, causes the area to contract. So we may have to do some type of range of motion to the area to prevent contractures, splint an area in an extension position because we know a contracture is a flexion of the position. We got to address those nutritional needs. Long term, we're worried about tissue rebuilding, repair. So if I have somebody that has a burn and I'm trying to address their nutritional needs, I have to think about they may need more calories, right? But they've got to focus on some vitamin C. That's going to help with tissue building and repair, and protein. So when I'm picking out foods for this individual, or I'm educating this individual about foods that would be good, I'm really going to focus on those foods that have a lot of protein and vitamin C to help with tissue rebuilding and repair. Psychological, we have to address the psychological components that can go on with a burn because of the potential alteration in their body image and how they look, so we have to be sensitive to that. And then mobility. Depends on if the patient's been immobile in the bed for a long period of time, they're having to relearn things, or just maybe they have a gait disturbance now because of their burn, or maybe the electrical damage caused some neurological loss of function as a result of the exposure to the electrical damage. Okay, so just to recap burns, you've got to really understand the physiological changes that go on in each phase. What physiological is going on in that pre-hospital or that emergency phase? What is going on in the next phase where all the fluid shifts are changing? In that emergent phase, because my shift is going to change. Then what goes on in the rehabilitation phase? I've got to understand total body surface area, Parkland formula, fluid replacement, addressing their airway, looking at their kidneys, seeing how their kidneys are doing, are they perfusing, what does their electrolytes look like in this patient. So a lot goes on physiologically when somebody has a burn, so we've got to really understand all those changes that go along with it. We're going to do some activities in class that'll help pull it all together. So make sure you go back in your Med-Surg book, make sure you read specific parts in your book, pay attention to some of the tables and the charts in your book because they do have some really good information in there. And we'll work some Parkland formula questions, and we'll do some total body surface area things in class. All right, y'all got this. Good luck.